Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Quresh B. Maskati, sir. And let me share some of the achievement of sir. Sir has done MBBS, MS, DOMS, FCPS, FICS, and he is consultant ophthalmologist at Maskati Eye Clinic, Mumbai. And today, sir is going to discuss on one of the most important topic, diabetes and the eye. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Faraz. And apologies, we are running a few minutes late because of some technical issues at the back office. But diabetes and the eye, as Faraz correctly said, is a very important topic because India is fast becoming the diabetic capital of the world, which is not a good thing to have. Uh, we have more diabetics than almost any other country in the world, and diabetes can affect the eye in various ways. First, let us again revise our basic anatomy so that when I talk about certain things, you know where we are. The front portion of the eye, like the glass in front of my Rolex watch, is called the cornea. Behind that, the brown portion is the iris, and in that, there is an opening in the iris called the pupil, which expands and contracts. Behind that, that yellow colored area that you see is the lens of the eye, which when it's transparent, it is the lens. When it becomes opaque, partially or completely, we call it cataract. Behind that is a huge empty space, which is shown in blue, which is actually filled with a jelly called vitreous humor. And behind that is the retina, which is like the film of a camera, like the old film cameras. Now, of course, mobile phones, we've forgotten what it was to have a film. But right at the back, just behind the vitreous, is the retina. And from the retina, 2 million cells of the retina, each one has a tail, as it were, and those tails all combine together and form what is called the optic nerve, which you can see behind, which carries the impulses, the images to the brain, where we perceive it as sight. So diabetes affects almost every tissue of the eye, and we will see. So just remember this little basics of anatomy, that the retina is at the back of the eye, and from the retina, the impulses go through the optic nerve. So diabetics are more prone to cataracts. They can occur in younger age groups. They can be more severe. They can be more rapidly progressive. They are more prone to glaucoma. Glaucoma is when the pressure in the eye rises, and when the pressure rises, it presses on the nerve of the eye, the optic nerve, causing damage to the nerve and loss of peripheral field of vision. So diabetics are 3 times more prone to glaucoma. The tears of the eye, which are required 24 hours to keep the eye moist and to give you perfect vision, that goes down in quantity and quality. So diabetics are more prone to dryness of the eye. And because of dryness of the eye, because of cataract, little changes in pressure, they can get fluctuations of vision. So diabetic might tell you that I see better sometimes and less better some other times. Their eye muscles are easily paralyzed due to nerve damage. So just like stroke in the brain is more common, similarly a stroke to the eye muscles or loss of the nerve sensation to the eye muscles causing a paralysis is more common in diabetics. We will discuss at great length the damage to the retina and optic nerve, and bleeding or hemorrhage anywhere in the eye or in the orbit around the eye. As you can see, like a black eye that this lady has got, the skin around, there is what is called ecchymosis or hemorrhage. Inside the eye also there is hemorrhage in the under the conjunctiva. It's called subconjunctival hemorrhage. It can happen with trivial trauma. It can even happen without any trauma in a diabetic. But let us focus today more on the most important and vision threatening, which is diabetic retinal disease. You must remember that the longer the duration of diabetes, the more the chances of retinal affection. So somebody who's been a diabetic, even excellently controlled diabetic since 25 years, has more chances of developing retinal disease than a diabetic who is poorly controlled only but has diabetes only since 3 years. So sometimes you'll get patients who will come to you crying, "Why me, doctor? I've been controlling my diabetes so well. I've taken all the medicines you said." That's just because the duration of diabetes. The more the duration, the more the blood vessels become brittle, fragile. New blood vessels form which can burst easily, giving rise to hemorrhages. There can be leakages of cholesterol in the retina, giving rise to what is called hard exudates. Of course, the worse the control, the more the chances of retinal affection. So, diabetic which is long standing and poorly controlled, almost 50 to 75% of them by the after 15 years of diabetes will have retinal changes. That's why it's essential that all diabetics must visit an eye doctor, not an optician shop, for examination of the retina, because we put drops, we dilate the pupil, and we have a look at the retina. What do we look at? We see, if you can see the picture there, the optic nerve looks like this. It is healthy pink with blood vessels coming in and out, arteries and veins, with no hemorrhages, no exudates. And the central portion, which is that black dot which is shown, called the macula, which is the most sensitive area. 80% of our vision is through that. So we dilate, we look at this area, and if you are in any doubt, we take pictures and so on. We take images. So this is all done by the eye surgeon, cannot be done by anyone else. And we call the patient if everything is okay. We may call after every year. If there are slight changes, we may call after every 6 months, 3 months, or whatever. So once a year, an annual eye examination is a must for every diabetic, whether well controlled or not. So what are the symptoms that a diabetic will have? He might have floaters, as you can see in the field of vision. He can see multiple black spots. He may have blurring of vision. There may be some areas of vision which are dark, because if there is a bleeding there, if there's a hemorrhage, then that area will appear dark. So you might have a reduced field of vision. Sometimes they have alteration in color perception. They don't see the colors so sharply. And of course, if it's late stages, the patient may say, my even central vision is gone and I'm seeing much poorly. So these are some of the changes. We call it diabetic retinopathy. If the retina is involved, we call it diabetic retinopathy. You get if you can see the arrow which is there, these hemorrhages which are there, and you can get cholesterol deposits. These are exudates or cholesterol deposits. For us, is my arrow visible? For us, may not be with us. Anyway, so these are the diabetic changes which occur. And afterwards, at the end, the nerve might fail us and give you a white nerve like this. Instead of the pink nerve, which is normal, you might get a white nerve called optic atrophy, where there is disc pallor. So diabetic retinopathy is divided into two main types. One is called non-proliferative diabetic retinopathy, or NPDR, which is in the early stages. This vision may be perfect, but it can be detected by the eye surgeon. And if we treat the patients well in time, a stitch in time saves 9. So with NPDR, tiny blood vessels leak, makes the retina swell. Only when the central area, the macula, gets swelling, it's called macular edema, then his vision will go down. But if in the periphery there is retinal swelling, patient may not realize it, but we can see it, and we can do laser, we can give injections, and we can prevent macular edema. So this is the common reason why people with diabetics lose their vision, because they don't come to the doctor in time. One of the tests we do is called an OCT. Just like we do a CT scan of the brain, we do an ocular CT scan, and this is what a normal macula looks like, with that valley-like thing that you can see in the first picture. This valley, this is the normal macula. But if there is fluid filled, then on the right side picture, you see this black area is all water logging, and it becomes like a hill or like a mountain. This is called macular edema. So other macular changes in NPDR, blood vessels in the retina can close off. You can get ischemia. As you can see, the blood vessels, instead of being nice and pink, some of the blood vessels are yellowish over there. So there is no blood flowing through that. Cholesterol may be jamming it, just like you get coronary cholesterol deposits. You can get it in the macula, called macular ischemia. When we take multiple pictures with various gadgets, we can see it much easier. So if ischemia occurs, blood doesn't reach the macula, and then sometimes these ischemic blood vessels can leak cholesterol. So you can get exudates or yellow spots that you can see at the macula. So if there is NPDR with macular involvement, vision will be blurry. So if there is macular, so you see this yellow deposits, and in the center there is hemorrhage. This is called circinate retinopathy. Circinate because it's like in a circle. So you can get some lot of these changes in NPDR. And then the second stage is called, more advanced stage is called PDR, or proliferative diabetic retinopathy. So in proliferative diabetic retinopathy, it's the more advanced stage. Now here you get new blood vessels growing, called neovascularization, or new blood vessels coming. So if you see the picture on the left, there are tiny blood vessels obscuring the disc, so many of them that you can see. So you get new vessels on the disc. It's called NVD, new vessels on the disc. And you can get new vessels in the periphery called NVE, or new vessels elsewhere. So here this picture shows new vessels on the disc as well as new vessels elsewhere. Now these new vessels are abnormal. They are very fragile. They can bleed very easily. If the blood goes into the vitreous, you get what is called a vitreous hemorrhage. As you can see in the other picture, this is a vitreous hemorrhage which is there. If there is few hemorrhagic spots, you might see them as just dark floaters. But if they bleed a lot, they obscure the field of vision, and there'll be a sudden blackout or a gradual blackout of the field of vision because of vitreous hemorrhage. If still this is not tackled, then those blood vessels from which leakages occurred, now they become scars. And these new blood vessels can form scar tissue. As you can see, this scarring which is there, all this scarring, see the disc also is becoming pale. And this is like ropes. And because they are like ropes, they pull on the retina. You can see this called traction retinal detachment. So the retina is being pulled, and the retina can get detached from the choroid or the structure behind. And this can steal both central vision and peripheral or side vision. So to reiterate, you get NPDR, or non-proliferative diabetic retinopathy. If there is macular edema, then you get drop in vision. If you don't treat these patients, they can go into proliferative diabetic retinopathy with new vessels, which can bleed, giving rise to vitreous hemorrhage. If you still don't treat, you can get scarring and tractional retinal detachments. So what are the investigations we do? I mentioned the OCT earlier. This is the normal OCT of the macula, which is like a valley over here. And if there is moderate edema, you get a little hillock like this with waterlogging. And you can see if severe macular edema, it's like Mount Everest over here with this black area that you see, this all waterlogging. So the vision becomes very poor, and we can actually measure the amount of macular edema, because then with our treatment, we can see whether it is working or not. So one of the investigations was OCT. The second is fluorescein angiography. Because of OCT now, fluorescein angiography is done less. We inject a yellow dye called fluorescein into the vein of the arm. The dye travels through the blood vessels, and a special camera takes pictures. It can be in color or in black and white. So whichever blood vessels are leaking, you can see the leaking blood vessels with the dye coming out with white area. If it is in the color, then you can see the green leakages from the blood vessels. And if there are abnormal blood vessels, it highlights those blood vessels also. So it gives you a lot of information. After doing this, we find out there is edema at the macula. We give what is called intravitreal injections of anti-VEGF. VEGF is vascular endothelial growth factor, which is something which is released in diabetes, which promotes new vessel formation. So we have got medicines called anti-VEGF medicines, which reduce the new vessel formation. Some of the trade names are Avastin, Eylea, Eccentrix. This is not the forum to discuss pros and cons, but all these anti-VEGF medicines help to reduce the swelling of the macula. They slow the vision loss and can perhaps improve vision. They're given by injections in the eye, as you can see in the picture above, where the injection is going behind the lens in the jelly of the eye, the vitreous. This is a color picture of the same. They are called intravitreal injections. We may have to give them repeatedly, once a month or once in 2 months or 3 months, depending on the injection. If there's a lot of macular swelling, sometimes we give steroid injections also, which works like anti-VEGF as well. And the other options that we have is laser surgery or photocoagulation. So we convert the hypoxic areas. Some areas are deprived of blood, but because they are hypoxic, because there is some oxygen going there, that acts as a focus to call new vessels to that area. We don't want those new vessels because the new vessels are fragile. So we convert those hypoxic areas into anoxic areas. So you see in the third picture, these are the laser marks which are done. So all these become anoxic. Anoxic means there is no blood supply. These areas are dead. Doesn't matter because 80% of our vision is in this central area. So no new vessels are forming, and with the central area, the central vision is very well preserved. Similar things are done when there is one large vessel is blocked in one side, like it's called a branch retinal vein occlusion, or if the central blood vessel is blocked, then you get central retinal vein occlusion. In both of these, we need to do laser photocoagulation. It helps to shrink blood vessels, prevents them from growing again. We may need to repeat the treatment as well. If there is a chronic vitreous hemorrhage or retinal detachment, the traction detachment that I told you, then we wait for 3 to 6 months. If it doesn't improve on its own, we do a surgery called vitrectomy, where usually 3 pipes are put into the back of the eye. One is the light pipe, which allows the surgeon to look at the back of the eye because it's all hemorrhage, so you can't see otherwise. One is an irrigation pipe, which pushes saline into the back of the eye. And the third one is a suction with a vitreous cutter. So it cuts the vitreous, cuts the hemorrhage, and it sucks it out. So one is irrigation, one is aspiration and with a cutter, and one is the light pipe. So if there are scar tissue, the hemorrhage, we cut it and take it out, suck it out. If there is scar tissue, the scar tissue is also cut with the vitrectomy cutter. So we do a B scan to find out the extent of hemorrhage, and then we do what is called 3-port vitrectomy. This is how it looks. 3 ports, because I told you 3 pipes have to go into the jelly of the eye, and then cut the tissue out and suck it out and replace it with saline. So to summarize, these are the early changes of diabetes, that is the non-proliferative diabetic retinopathy, few hemorrhages, few exudates. In the late phase, again, more exudates and more hemorrhages. And this is where laser helps. Laser doesn't help when once proliferation occurs. To summarize, the management of diabetic retinopathy has made huge advances in recent years with better diagnostic gadgets, excellent operating microscopes and gadgets such as lasers and vitrectomy machines, and newer medicines such as the anti-VEGFs. However, the most important thing is prevention with diabetes control, and regular eye checkups with your ophthalmologist are essential to keep your eyes serving you well for as long as you live. I'll be happy to answer questions. I apologize if I've hurt anyone. I hope I've not given you information overload. We did run a little short of time, but I've tried to compress all this into a capsule for you. Thank you so much for your attention. Faraz, over to you.
Thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participant doctors who have joined during this session. Sir, as I can see, we have received some questions. With all your permission,
Yes.
shall we take?
Yes.
The first question I can see from Dr. Maharajam, and he's asking, can you discuss the spectrum of diabetic retinopathy from non-pro refractive to pro-life refractive stages and the management strategies for each stage?
Yes, I think Dr. Mariam has not attended the lecture. Maybe she can re-see it on YouTube or whenever it is available for us, because I spent the entire lecture just discussing the management from pre-proliferative or non-proliferative diabetic retinopathy to proliferative and the steps that we take. Just to summarize, in non-proliferative diabetic retinopathy, if there is macular edema, we give intravitreal injections. But otherwise, if we see the neovessels, if we see the leakages and exudates, then we might apply laser treatment. In proliferative diabetic retinopathy, we need to give anti-VEGF injections. And if there is vitreous hemorrhage and scar tissue, then we need to do a vitrectomy and restore vision. Thank you.
Thank you so much, sir, for sharing your insight on this question. Moving forward, another question from Dr. Shruti, and she is asking, how do systematic factors such as glycemic control, blood pressure, and lipid levels influence the progression and severity of diabetic eye disease, and how can these factors be optimized to reduce the risk of vision loss?
So, as I said, the duration of diabetes is most important, even with good control of diabetes with a low HbA1c levels. Even then, if the patient has got more than 15 years of diabetes, there are more than 50% chance that they will get some retinal changes. But retinal changes, if we see them early and the eye surgeon treats them in time, we can prevent blindness from occurring. So an annual checkup with the doctor is most important, and the better the glycemic control, the less chances of blindness in future. Thank you.
Thank you so much, sir, once again for sharing your expertise on this question. We will be taking one last question, sir, from Dr. Avnish Patel, and he is asking, are there any emerging pharmacological therapies or treatment modalities on the horizon for diabetic eye disease, and what evidence support their use?
As of now, we are the research is mainly into different types of anti-VEGFs, vascular endothelial growth factors. There were first only one or two. Now there are about 6 or 7 different anti-VEGFs, and they are trying to reduce the number of injections per year. In the older anti-VEGFs, we have to give the injections once every month, but now we have got some anti-VEGFs where we can give them once every 3 months and even once every 6 months. They're also looking at newer intravitreal implants which will be put into the eye, which will slowly deliver anti-VEGFs over time, maybe 1 year or 2 years, so that you won't have to give repeated injections into the eye. Thank you.
Thank you so much, sir, for answering all the questions of the participant. I hope, sir, you have done justice to this topic. As of now, we don't have received more questions, sir. You have cleared all the dots related to this topic. Sir, as there is no more questions, with all your permission, shall we conclude this session for today?
Yes, please. Thank you.
Yeah, welcome, sir, and hope to see you again in future also with different topics, sir. Till then, take
Thank
care
you.
of yourself, and sorry once again for all the delays, sir.
No
Take
problem.
care, sir.
Okay. Thank you. Bye bye.
Welcome, sir. Bye.